Hi, everyone, and welcome back to Burn the Rulebook Podcast. This is the podcast where we break down everything you were never taught about menopause, mental health, and relationships one truth at a time. I'm Rachel Boyle, a licensed couples therapist, sex therapist, and certified menopause specialist. This podcast helps you understand what is actually happening to your body, mind, and relationships, and gives you real tools to move through life with clarity, calm, and connection. Let's get started. Hi, everybody, and welcome back to Burn the Rulebook Podcast. Today, I have a very special guest with me. Her name is Cherie Little, and she is a nurse practitioner out of Las Vegas, Nevada. And I'm going to read a little bit about all that she's accomplished. So Cherie is a doctorally prepared, dual certified family and women's health nurse practitioner. She's a retired Air Force veteran, and Cherie has experience in primary care, women's health, military medicine, labor and delivery, postpartum, medical, surgical, inpatient medicine, and aeromedical staging. And also she is super trained and experienced in women's sexual health, specifically perimenopause and menopause. Cherie is a board certified family nurse practitioner by the American Association of Nurse Practitioners and board certified as a women's health nurse practitioner by the National Certification Corporation. She is also board certified as a Menopause Society certified practitioner through the Menopause Society, and she maintains memberships with ISWISH, which you hear me talk about a lot, International Society for the Study of Women's Sexual Health, and the Menopause Society. Okay, well, welcome, Cherie. Thanks so much for being on the podcast.
Thanks for having me. I'm super excited.
Yeah, I'm so glad that you're here. If you're okay with telling us a little bit about how you got started, how did you decide to specialize in women's sexual health?
Yes, I would love to. And let me just say, the way you just said all that, I want to just replay it whenever I'm feeling like my...
That's all the hard work that you've put in to help other women.
Yes. So I got into my love of hormones because I was doing primary care and then I did urgent care. And I've always loved women's health and just from my days, labor and delivery and postpartum. And I had all these women that were asking me to do hormones or check their hormones, right?
Sure.
And I would check them and they were normal. And so I'm like, well, I don't know what to tell you because they're normal, like the majority of people that have been trained in the last 20 years. As a women's health nurse practitioner, I had one course on menopause and it was after the Women's Health Initiative. So it was like, ooh, hormones may not be the best thing for you. And so I didn't have anywhere to send these women. So eventually I decided that urgent care was not my love. And when I went back and restudied hormones and the Women's Health Initiative and learned from the Menopause Society, I was dumbfounded and flabbergasted and said, these women need to be helped. They need an advocate. And by golly, we're going to figure it out. So that's where.
Well, thank goodness you did, right?
Yeah.
You're helping so many women. I'm so glad to have you out there in the world.
Yes. I love, honestly, there's not a more rewarding thing. Like every day, I love what I do. Yes. Yeah. This is my passion. Yeah.
Same. Yeah. Okay. So a lot of women are confused about perimenopause and menopause. And some women aren't even sure about, when does perimenopause start? What are the signs and symptoms? Pretty much everybody knows about the hot flashes, right? Hot flashes get all the news, right? They get all the glory, right? But when I first started, it was more than just the hot flashes. And so what are some of the signs and symptoms that women might have that maybe some women don't know about?
So good question. I think the very first thing is usually our cycles start to change a little bit.
Okay.
And it may not necessarily be that they're starting to space out, but maybe the way they're presenting is changing. They're more heavy, they're more painful, or you're spotting, whereas you used to be heavy. Maybe it's not exactly every 30 days. Mood changes, more like low mood the week before, the week of your cycle. Depression, anxiety is a huge one. And
anxiety is a huge one. I see that a lot. Yeah.
And then joint pain, because we're all just like, oh, we're getting older. I guess my joints are hurting. Well, maybe not. Could be something else. And then what I always say too is the hard thing is a lot of women, they think they're too young. They're too early for it, right?
Yeah.
And so I always tell women, look, talk to your mothers, talk to your aunties, your grandmothers, your sisters. When did they go through menopause? And you can honestly have symptoms for 8 to 10 years before. You can start early. I have women as early as 39, late 30s in my
Oh,
clinic because
sure.
their mothers go at 45, right?
Yeah.
So it's not a later thing for some women. So be looking for it early.
I would agree with you. And, I delivered my son and then turned 35 and then I breastfed. And then I never felt like my hormones bounced back afterwards. So at 37, I was having some hot flashes at night. But the thing that I noticed the most was the aches and pains, right? Which
Mhm.
we now have a term for that thanks to Dr. Vonda Wright.
Yeah.
Skeletal muscular syndrome of menopause. It's a mouthful. And I also had anxiety.
Oh, yeah.
Yeah. So those were the two things that I noticed the most, even more than the hot flashes. Those are the things that sent me to the doctor.
Yep.
Yeah.
About 18% of women won't have hot flashes at all. So some
Okay.
will just sail through
Okay.
and you're going to feel the worst like in that final year before your cycle stop. That's really when like hot flashes and night sweats are going to be the worst.
Okay.
So early on in peri, you may not have that at all. The signs
Okay.
are going to be very subtle.
Okay.
Yeah.
Yeah. No, that's good to know because, a lot of women in their late 30s, they start coming into therapy. So I see them in my practice, right? They've got anxiety, maybe they've got depression, they're starting to have problems in their marriage or relationships, or if they've had some issues, now they're starting to get worse because
Yes.
of that emotional component that happens.
Yes.
Yeah.
And it's so hard because like, we don't know why we feel the way we feel or
I don't
what's
know.
we don't even know what's going on with ourselves.
Nobody's even told us. What's up
Right?
with that?
Yeah.
No one's told us this.
And we're like, we all feel fine when we're alone. When no one's
Yeah.
around us, we're great, right?
Yeah.
So
Yeah.
it's like, you don't even think that it's your hormones, right? You're just like, I don't know what's happening, but this is how I feel right now. So yeah, it's a
Well,
thing.
and if no one has been told you this, right? I mean, we barely learn about our periods from our generation that we grew up in, right? No one taught us about perimenopause, so that it's just like this stuff is just happening, and women start to feel like they're going a little crazy or that there's something really, really wrong with them, and it's just perimenopause.
Yep. Yep.
Yeah.
You're right.
Okay, so can you tell us a little bit about what treatments are out there for women? What can they do? What's available for them to help them feel better?
In perimenopause and menopause. So I kind of talk about it all together.
Okay.
So I would say early stages, you can always, I always start with lifestyle, right? If we're not eating healthy, if we're
Right.
overweight, depending on some of the things you're putting into your body can trigger it, right? So women who are overweight are going to have more severe symptoms
Okay.
of hormone deficiency because that estrogen will sit in the adipose tissue.
Okay.
So weight loss, which is a catch-22 because in perimenopause and menopause, you have a hard time losing weight.
Yes.
Yes. So I understand that, but trying to maintain a healthy lifestyle. So stress management, exercise, right? Get your sleep at night,
Oh, absolutely.
nutrition.
Yeah.
Alcohol can trigger symptoms, hot flashes specifically. Caffeine can trigger spicy foods. Anything with temperature that's going to increase it, that can trigger it as well. So just a good old-fashioned lifestyle modification, right?
Okay.
That's making you your best version of you is then going to help your body regulate its hormones as best as it can.
Okay.
Higher stress is going to drive your cortisol, which is going to steal your hormones. So stress
Okay.
management, huge.
Okay.
You can do supplements. So soy foods, plant-based estrogens, and wild yams, those can
Okay.
help as well. So if you like those, add those into your diet and see if those can help. And then, of course, there's non-hormonal options that you can do. Typically, like Veoza is a newer one. And
Okay.
then traditionally, we've always done like SSRIs, which are the selective serotonin reuptake inhibitors. Those are more of your antidepressants, anti-anxieties. And then there's hormone therapy.
Okay.
And so hormone therapy is a whole nother question because I can go on for days.
So let's do that. Let's talk about the hormone therapy.
Okay, so hormone therapy, you're looking at estrogen, progesterone, and testosterone.
Okay.
The first thing I always like to tell people, there's a lot of fear around hormones. And
Yeah,
so
let's talk about that because there really is.
there
Since
is.
the WHI came out. Yeah.
Yes. And so the fear, one of the issues when we say hormone therapy is not all hormones are created equal. So verbiage and language really matters. So a
Okay.
progestin is a synthetic progesterone. It's not the same as a bioidentical progesterone. So estrogens versus estradiol, right? So the verbiage matters. The Women's Health Initiative was a study that came out in 2002. It was a huge study across the US. I think it was like 45 different centers and like 25,000 women. Huge study. The average woman, I think she was like what was it, 50 to 79, maybe 60 to 79. My numbers might be off here. The ages on it, let me see, 50 to 79. I wrote it down in preparing for
Nice.
this. So 50 to 79. But the average woman was truly like over the age of 60. They were not studying them for actual menopausal symptoms. They were looking at cardiovascular risk reduction. So that was the
Okay.
purpose of the study. However, this is the largest study that we have. So we are able to pull a ton of information from it. But the study was not done well. So they gave them synthetic hormones, synthetic estrogen and synthetic progesterone. What are synthetics? Let me caveat that because that may be a new term as well. So synthetics mean the molecule, the actual chemical formulation of this hormone is not the same as our human form, right? So a
Okay.
classic example is conjugated equine estrogen. So
Oh,
for
right.
years, we've taken
Premarin,
pregnant
right?
horses. Yeah.
Yeah.
We've taken pregnant horses' urine, pulled the estrogen out, and put that in our pills.
Okay.
And so we're not horses. So those extra horse pieces, innately, our body is not going to know what to do with. So if you're looking at something like that as synthetic, that's not natural to the body versus bioidentical, that is natural, right? So your
Okay.
body's going to see that and it's going to say, this is my estrogen or this is my progesterone.
Okay.
Less side effects with bioidenticals. So first of all, Women's Health Initiative used synthetics. They
Okay.
found an increased risk of blood clots, breast cancer, and strokes.
Right. That's what scares people.
It is, but here's the piece. That study was supposed to go for 10 years. They cut it off at the 5-year mark. All the investigators that were actually running the study were not involved in writing the report. They took it to press and gave their review that it caused those things. Now, remember, this was back in 2002 when people still watched the news and there were still newspapers, right? Social media wasn't really a thing. So it rocked the news waves. Okay. So roughly 80 some percent of women that were on hormones dropped down to like 18%. Clinicians stopped prescribing hormones because we don't want to cause any of those things for our patients. And over the last 20 years, they've actually pretty much stopped teaching it to the majority of universities because what do we have now? We have the antidepressants and the anti-anxiety meds if we're not going to do hormone therapy for these women. Now, in the meantime, we have gone back and regurgitated and redone this data and pulled and reran these numbers multiple times and have found that their statistics were not actually significant. So their findings did not, any study that you do, it has to reach like a 0.95% confidence interval to be statistically significant. And it wasn't. And the investigator said, well, it was close. And we're like, yeah, that's not really how it works. And so when they have now gone back, all of the investigators from the Women's Health Initiative have formally recanted their statement and said it does not cause those things. It does not cause breast cancer. It does not increase your cardiovascular risk. But we're now in a world where we can't get that message back out, if that makes sense. So we are trying to re-step and re-pull back, and that message is not going out the same way that the initial message went. So there's still a ton of fear out there of surrounding hormones, but the key takeaway is they use synthetics. If we're doing bioidenticals do tend to be safest. Now, there are some women that will still need synthetics, and that's okay because it's really about the woman and what she's using it for. And as long as we understand the risks and we pull the data correctly, then that's shared decision making.
Right. I think that shared decision making is so important. And one of the things that I talk to so many of my clients about is finding a properly trained clinician.
Yes.
So they can get all this information that you're saying. And my struggle is that I refer my clients, because I'm not a doctor, I'm a therapist. I'm like, okay, you need to go speak to a medical provider, and then they go talk to someone, and then they come back with inaccurate information.
Yes.
Right. And now they're scared to start on hormones, which I understand because I had a family member who was a doctor that told me not to start HRT because I was going to get breast cancer or blood clots.
Yes.
And so it really delayed my starting HRT. So I continue to have all these bothersome symptoms.
Yep.
So I can understand people's hesitancy around that. And so what you're saying is that the original information that they came out with the WHI has actually been taken back, and they've come out with new information because they found that the information that was released was not accurate. And so the risks for breast cancer and heart disease are not valid like they were 20 something years ago.
Well, it's hard to take a study that had so many women with multiple different medical backgrounds medical histories.
Yeah, because
Medical
they were older too, right?
and older.
And older.
Generalize that across any woman that walks in the door,
Got
right?
it. Got
So
it. Yeah.
so I won't say all are safe because that's probably poor form and a bad generalization, but in general, it's not what we were once told. And so
Okay.
we know that estrogen by itself is actually breast protective. We see a decreased risk in breast cancer if you're on estrogen only. Yep.
Wow.
Yes.
That's huge.
Yes. Right?
Decreased risk. Okay.
Decreased
Yeah.
risk, yep, 4 in 1,000 less risk of breast cancer. It
Okay.
was the synthetic progesterone that worsened our risk. So women
Okay.
who were on estrogen and synthetic progesterone, they
Okay.
had a worsened risk. So if you do bioidentical estrogen and bioidentical progesterone,
Yeah.
then your risk on those hormones is the same as your risk not on those hormones.
Got
Now,
it.
that study was only done for 5 years. So we don't know the long term, but it appears to be equivocal.
Okay.
So isn't that huge? Because we are
That's
all yeah,
Yeah, no, that's massive because I'll have clients that say like, "Well, I don't like to take medicine. I don't want to put any kind of pills or in my body." So when you're saying bioidentical, right?
it's what you already have.
It's okay, so then you're not putting something in your body that's different than what your body is already
Correct,
producing?
correct.
Okay.
Which that makes sense because if
Yeah.
you think about this, when people are like, well, I'm trying to think of a good example, but if people are like, oh, is this going to harm me? And it's like, well, you already have estrogen.
Right.
Right? You already have progesterone. So it's
Right.
like, I don't, it like if you think about it that way, this is what you already have. All we're
Sure.
doing is raising the level back up so that you feel better because it's this significant drop that's giving these women these symptoms, right? And then the other thing, because I'm not sure if we're going to talk about this later, so I get excited. I want to tell you about it now.
Tell me about it.
We do not do hormone therapy. It's not FDA approved for prevention. But we know that there are benefits. There are huge
Mhm.
benefits to it. So estrogen is a vasodilator. So it actually relaxes the vasculature, decrease our risk of non-fatal heart attacks by about 4 in 1,000 women. It
Wow.
can increase your bone density. So women who are on hormone therapy can have up to 7 less fractures.
Well,
So
that's
I always
super
tell
important.
women, think of yourself when you're 80 years old and you
Mhm.
fall. You're less likely to break a hip, right?
Mhm.
Dementia. It prevents dementia and what can help prevent dementia. It increases your insulin sensitivity.
Mhm.
These are all things that our natural estrogen and our natural progesterone have been doing for us. So it baffles me because I think about this and I'm like, wait a minute. When we go through menopause, do we just naturally all become overweight, get high blood pressure, become diabetic? Or did our estrogen and our hormones tank? And now we're seeing the ramifications of lower levels. So it's interesting.
Well, and these I think are important issues because these are the things that take little old ladies out, right? The
Yeah.
broken hip,
Yes. Yes.
UTIs, which we haven't gotten to yet, but that's another one that can kill somebody. Most people don't realize UTIs can be deadly.
Yes.
Yeah.
Yes. Yes.
So can you talk a little bit about where people can get bioidentical? Because back in the day, right, you could only get bioidentical hormones from a compounding pharmacist because no one could prescribe them because the WHI scared off all the prescribers, right?
Yep.
So
Yep.
a lot of people think that they're super expensive. So can you talk about
Of
where
course.
people can get them and what's happening with that?
Yes. So I love that because that's something I tell all of my patients as well is there's misinformation that bioidenticals are only at compounding pharmacies, and that's not
Mhm.
true. So you can do bioidenticals through a regular pharmacy like CVS, Walgreens, Walmart, and your insurance will most likely cover all of it or a portion of it. Estrogen patches, for instance, a 1 box supply of estrogen patches is roughly about $30 in my area in Las Vegas.
Okay.
The oral progesterone capsules are like $20 a month. And those are prices without insurance.
Oh,
So
wow. That's really
$30 and
affordable.
$20 without insurance. So you
Yeah.
use your insurance for it and you may not pay anything at all.
Okay.
But yes.
Yeah, so with my insurance, the insurance that I had last year, I had 0 copays. So all my HRT was
Nice.
completely paid for. I switched to a new insurance. And so now it's $30 for everything,
Yeah.
progesterone and estrogen, and that's for a 3-month supply.
Well, that's awesome.
Yeah.
Yeah.
Yeah. Yeah.
That's really good.
Now the testosterone, I still have to get at a compounding pharmacy. So can you talk a little bit about testosterone, right? Why women have to get it from a compounded pharmacy or they have to finagle the male level dose?
Yes. Yeah.
Okay.
Because
Yeah.
so testosterone is not FDA approved for women. And so there is some, testosterone is thought to be a man's hormone.
Right. We've gendered our hormones that everybody has. Everybody has all three, right?
Yes,
Progesterone,
yes.
estrogen, and testosterone.
And
Yeah,
actually, women
everybody.
have more testosterone than estrogen. But when you look at your lab results, for all of your listeners, when you look at your lab results, you'll think that your testosterone is less because the measurements are not equal the way that they come across on your lab. So it's like 1,000 testosterone to an estrogen, basically.
That's so confusing.
It is. It is. And so, but we have a ton of testosterone in our bodies. Yes. So you can do compounded testosterone because generally speaking, that's how we can get it down to a level for a woman. The replacement level for a woman is usually roughly like 1 to 5 milligrams.
Okay.
So how I usually do it is I do start women on a compounding because I like to tell them some women need a sniff of testosterone, some women need to be
Mhm.
drowned in testosterone.
Yeah.
So I start on the compounded and I basically test her out. Is she a sniffer or a drowner? Love my terms, but that's how.
I like it. No, this is great because I was a sniffer.
Yes, some
And
women
I didn't
are.
know that until I got on and I was like, my testosterone shot up. I mean, it wasn't that high, but it was higher. Not
Yeah.
like I was gonna have any side effects from it being too high, but I was getting some headaches.
Yes. Yeah.
Yeah.
And so if they're a sniffer, then I have to compound it because to get down to like 1 or 2 milligrams, I have to
Yeah.
compound it. So when you compound it, that's my ability to like determine the recipe for you, right? Big pharma, if I order it through the regular pharmacy, there's only certain concoctions that we can order. Like I can't ask for a specific thing. So the other way that you can do it, once you get to a level that if they're a drowner, for instance, then I can order it through CVS, Walgreens, Walmart. We do use a man's dose at a
Okay.
woman's level, meaning testosterone is testosterone, right? So it's
Right.
not a man's testosterone in that medication. What we do is we take their tube, because one tube, they put on 50 milligrams a day. So they'll put that whole tube on. For us, we make that last 10 days.
So it's
So
1/10.
it's 1/10.
Okay.
So here's
Yeah.
the thing is if it feels kind of a little wackadoodle because what you're doing is you're trying to get like a pea size out on that tube every day.
Sure.
And so you're like, how big is a pea, right?
Right?
And so you just make it last 10 days and that's going to give you about 5 milligrams. So if you can tolerate 5 and you feel better on 5, then that's your answer.
Got it.
And the reason that works is because long term, it's going to last almost a year. It's going to be about 300 days
Oh gosh,
because
that's
they give you
fantastic.
30 tubes in a box. For a
Yeah.
man, that's a 30-day supply. For us, that will be almost a year, 300 days.
Okay.
Yeah. So I kind of do a combination of the two. I test you out because just like you, some women, as soon as they use it, they're like, "Ooh, I don't know, Cherie, that may not be my thing." So we kind of have to see first.
Well, and I think this is really highlighting why it's so important to have an expert in the field like you to look at all these different combinations because every woman's body is different, right?
Yes. Yeah.
Right.
Yeah.
So, not every woman is going to just get a standardized treatment
Yeah.
approach,
Yeah.
right? Especially
Exactly.
in perimenopause, where things are literally changing daily,
Yes.
with
Yes.
those wild fluctuations, that it's important to have someone that's available, right? That you can go
Hmm.
see as an expert
Yeah.
that can modify your treatment plan,
Yeah. And I will
right?
say too, like, so here's the thing for the menopausal women, we've struggled just to be able to treat them, right?
Yeah. Right.
So that's what the Women's Health Initiative was based off of. They weren't even looking at perimenopause. So perimenopausal women, truthfully, that's even a subset where there's not a lot of data. There's not a lot of research on it. And so we're treating them knowing that we're helping and they're feeling better. But that's in my opinion, it's more complex. That's more of a moving target because as she's going closer and closer to menopause, her symptoms are likely going to get worse. It's almost easier in menopause because then you can it's steady state at
Right.
that
She's
point,
just at
right?
zero, right? Pretty
Yes.
much her
Yes.
hormones are zero.
Yes. And
Yeah.
so what I have found, even for myself, because I'm perimenopausal and I'm on hormones, it's hard
Yeah.
for me to even find someone to treat me Like, who do I go to? I don't treat myself as a practitioner,
Who does
right?
the expert go to, right?
Yeah,
Yeah.
like, I have
Yeah.
family members in other states that are like, "Who can I go to?" And I'll tell them, and they'll say, "No, they told me I'm not menopausal yet, so they won't treat me." And, so then I had to find other solutions. Okay, go this route. And so for perimenopausal women, I think it's very difficult because for the average woman, what I usually ask them is I say, have you, like I did a social media post on this. I'm like, have you put the signs together?
Yeah.
Because we just, as women, get used to feeling the way we feel. We just keep taking the punches and we keep going through life because we've got work, we've got kids, we've got all of this. And you're like, okay, today this hurts. Tomorrow I got this. And eventually we have to sit back and say, okay, this might actually be something. It's not just me struggling every day. And then
Right.
to go find someone to help them. And then that's going to consistently change over the next few years. So perimenopausal women have a soft spot in my heart.
Well, yeah, you're in it, right? I'm in it.
Yes.
So I read that the average woman sees 5 specialists before they're even told you're perimenopausal.
Yeah. I believe that, definitely. I see that all the time. I've had a patient that went to every ologist you can think of. Like they're a pulmonologist, an endocrinologist, like they were working her up from head to toe, all the
Yeah.
ologists. No, it definitely, it's there, it happens. And the biggest thing is because it's so ambiguous, but the biggest thing I hear is I'm not myself. So
Oh, and they did a study on that too, right? There was a study. Yeah, they did.
like women will say, I don't feel like myself.
Right.
And so how do you portray that when you go into a doctor's office? Because as health professionals, we need to know what is the problem and how do I fix it? But I'm not myself is so vague. But that's the number one thing is we don't feel like ourselves and we just need help.
Well, and we do need help, and it can be exhausting for women who are trying to find treatment because they're at this, you know, midlife age, right? So they've probably got teenagers in the house.
Yeah.
And so I tell my clients like perimenopause is puberty in reverse.
Yes.
So if you're going through puberty in reverse with all those mood swings, and then you've got a teenager who's going through puberty, that's just chaos. It's a
Yes, it
recipe for
is.
disaster.
It
And,
is.
and then a lot of times at this age, sometimes women are caring for their aging parents at the same time.
Sandwich effect.
The sandwich effect. And if they've decided to have a career, they're usually at the height of their career by the
Yep.
time they're in their mid 40s. So all of this is coming down, and then women aren't feeling like themselves. They're getting brain fog. This is what I see showing up. They've got brain fog.
Yep.
They loss of confidence. That's a huge one for career women. Loss of confidence,
Yes.
right? And then they loss of libido.
Hmm.
They might be having pain or uncomfortability with sex, and
Yes.
they just have been dealing with it, right? Because they think that that's normal.
Right.
So, and then they're having issues in their relationship with their partner or their spouse.
Yes.
So that's what I see on this end, on the therapy end.
Which you told me something years ago that always stuck with me, like the rate of divorces and suicide rates, right? For
Yeah.
menopausal women.
Yeah.
Yeah. Well,
Yeah.
and I would say even perimenopause. I don't think perimenopause was in that, but I'm sure that we can extrapolate that
Yeah.
down.
Yeah.
Yeah.
For sure. So the highest rate of divorce is in perimenopause,
Yeah.
right? And so it's like, from a therapy standpoint, I'm always looking at, okay, so the hormones are absolutely an important piece, right? So
Right.
I've got this structure now that I talk about with women, and it's like 4 legs of the chair, right? These are the 4 pillars of relationship. And the first is medical. The medical is the HRT, which you're talking about. It's that diet, the exercise, the doing things to help you feel good in your life, which is everything we're talking about today.
Yep.
And then we have, do I like my partner? Right? So you you can love your partner but not like them. So those are the relational dynamics, right? That I talk about in therapy. Do I like the sex I'm having? So, because there's a lot of women, we're not even taught about how to have good sex. What does that even look like? Have we even thought about if I were to orchestrate this how I wanted it to be and feel,
Right.
what would that look like?
Right.
And then the fourth leg is, the patriarchy, but people really get scared off by that word. So I'll say things like the cultural influences that we have. The
Right.
cultural influences that, as women, we're taught to minimize our needs. We're taught to walk around not feeling good, right? To put things off that are uncomfortable or painful, to just take it,
Yes.
to
Yes.
overfunction in life, just to keep doing things for others, to show up, putting everybody first. These are all those
Caregiver.
cultural influences. And then you've got
unfortunately, the medical field backing that up by unintentionally telling women that this is just aging, right?
It's
I'm sure
normal.
it's
Get over it.
normal to feel this way. I can't
Yep.
remember how many times I was told I just needed to get better sleep. I needed to sleep more.
Yes.
And that aches and pains were just a normal way of life. That's just what
Yes.
happens as you get old. I'm like, dude, I'm not that old. I mean, I don't feel like that. I'm in my late 40s now, but it's like, there's another half of my life left.
Yes. Yes.
Yeah.
Yeah, exactly. Yeah, I know. And I think, I always tell people, because you're right when you say like, that's what we're told. And the majority of patients say they go to 5 different people, right?
Yeah.
5 different practitioners. I always tell them, I relate it to when mom tells you don't touch the stove. Right?
Oh, right. This is good. Yeah.
Yes.
Yeah. This one's good. Yeah.
When mom said don't touch the stove, because, again, I went through a women's health program and was told, the Women's Health Initiative, basically don't do hormones. For the longest time, I was scared to even do vaginal estrogen. Like in primary care, I was like, estrogen, whew, that's bad, right?
Yeah. Yeah.
And it's like when mom says, don't touch the
Don't
stove.
touch the stove.
Your institute of education is mom. And you just want to help people. You never want to harm them as a practitioner. So
Sure.
you never go back and say, okay, is mom right? Like, does mom even know what she's talking about? You never ask. You just don't touch a stove. And so I always tell people, I'm like, you were asking them to touch the stove. And so now we're changing that narrative. And now there's like, the FDA just met, right? Like on July 17th, I think it was.
They did.
Yes. And so I'm
they
so
did.
excited. I was watching that live in between patients.
Wasn't that great?
Yes, yes. And so I'm so excited because just like we were talking about earlier, that verbiage matters. There's black box warnings across all different estrogen formulations, right? Well, not all are the same, and the way you get it into the body matters just as much. And so I think times are changing, and I think more and more people are getting on board. And so I think, not even 5 years down the road, I think we're moving pretty quick, to be honest, which I'm super excited about. And so, I think it's a thing that practitioners are still nervous because they don't want to touch the stove. But I think in time, they'll figure out it's not hot.
Well, I think that's happening more and more, like, because not only were you not trained on perimenopause and menopause, but you were just told don't prescribe, right? Or you're going to burn yourself, right?
Yep.
You're going to lose your license.
Yes.
In some way. And that's scary because you've put so many years into educating yourself and training and, working and now having your own practice. And it's the same with therapists. I had 0 training, by the way, 0.
Right.
Here I am, an educated therapist experiencing anxiety. I'm like, what the hell is this? I'm sitting on my couch, just waves of anxiety. I know what's happening. I don't know where it's coming from. And so, because I didn't even know I was in perimenopause.
Right.
So if those of us who are super trained in the world don't know what this is, then how is, every other woman out there supposed to know what's happening?
Exactly.
Yeah.
Exactly. Even myself, a few years ago, I went back on birth control because my cycles were getting irregular. That was before I went and got certified.
Yeah.
And then probably about 6 months ago, I was waking up every morning with joint pain. And I'm like,
you got
and it wasn't, and literally, we don't think about ourselves. It took me like a week and a half for that to snap in my brain. I'm like, hey, Cherie, you should have known this. But when it's yourself, you don't pay attention.
Yeah.
And then I found someone to flip me over from birth control to bioidenticals because the birth controls, they'll help. They were helping with my cycle, but they weren't helping with the majority of the symptoms. So
Okay, so can we talk a bit more about testosterone?
Yes.
And libido?
Yes.
And because this is the question, this is what I have so many women, they show up in my office and they're like, I don't even think about sex anymore.
Yeah.
It doesn't even cross my mind. I could go the rest of my life. And these women are in their late 40s and early 50s.
Yes.
Yeah.
Yeah. No, I hear it all the time as well.
Okay.
But for me, how I do it is I usually recommend increasing their estrogen first.
Okay.
And the reason is because estrogen is a vasodilator. So a lot of times that libido goes hand in hand with lower sensation as well and low lubrication. So if maybe it's not hurting, but if lubrication isn't there, if sensation isn't there, and we have the orgasm gap, like you've talked about before, then it's like, why do we even want to, right? Like, why are we motivated to jump into the sack? So estrogen will increase blood flow to the genitals, and it can also help with your libido. So if her estrogen is not right to begin with, I always start there and I get that up, and then potentially add in testosterone after that. And so again, yeah, women can be nervous about testosterone. And I just tell them it helps with brain fog, concentration,
Yes.
energy,
Yes.
libido, and
Yes.
orgasm.
Okay. So this is just my personal experience, right?
Yeah.
I'm an N of one.
Yes.
So we started estrogen and progesterone, right? And
Mm-hmm.
I noticed huge differences like within the first couple of weeks. My libido was still really low and I was still having anxiety. Whenever the testosterone got added in,
Yes.
the anxiety went away.
Nice.
Like, I don't know that that's going to happen with every woman, but I have to tell you that was the biggest thing and the brain fog, my energy levels went up. So brain fog got a little better with the estrogen, way better with testosterone. Energy levels got way better with the testosterone, and my libido started to come back.
Yeah. So you need it. You need it for sure.
Yeah.
And that's so a lot of women, I'll put them on testosterone, but I tell them, I'm like, if you can't tell what it's giving you, then I pull them back off because I'm like, it should be giving you benefit. So for you, you're getting clear benefit, which is great. We hope for all women, but I think there are some times that we try it and it doesn't always work.
So I've heard that, right? That if you're going to have benefits from increased libido, it takes a few months?
It can take a while.
Okay. How long does it normally take?
I tell them you're putting on testosterone today as an investment for next month.
Okay. So at least 30 days.
Oh yeah. And honestly, I think 30 days for energy, you'll feel your energy come up first, like mood energy, and then libido comes later. So I would say definitely like 3 months. And
3
then
months.
and then what I usually do is I'm then increasing the dose. So what I do is I start them on the low dose, right?
Yeah.
So 1 to 5 milligrams for testosterone, but I usually start at half of a milligram and I tell them to stay there for about 2 weeks and then go up to 1 milligram.
Okay.
I do that because some patients, as soon as I've put them on it, they just haven't liked it. They've had a side effect. So I'm really going slow to make sure there's no side effects before they go up. But then after like a month or two, I'm increasing the dose because either, you can't just try testosterone and say it didn't work. Maybe it wasn't the right dose. So then we're getting you up to the dose that, a higher dose. Are you going to feel this one? And we check your levels. And so for some women, they won't respond to testosterone, but the good majority do. Yeah. And the majority of women actually really like how they feel on testosterone.
I had a client of mine that told me that she started to have erotic dreams again. Oh. I thought that was pretty cool when she started on the testosterone. So it went from 0 to I've got a little thought now, just a little thought.
Yes.
Right. And I think sometimes women worry that they're going to become like raging hormones. Like they're just, like they're going to
like
get manly and muscly and deep voice. And they're going to want sex all the time.
Yes. Yes.
What do you want to say about that?
I don't see that at all.
Yeah.
I don't see that. So the risks of testosterone. So sometimes when you're starting it, you can get some transient acne. And usually that goes away. It's like a week or two. You may see a couple and then it'll go away. Okay. Honestly, it's not common.
Okay.
I think I've seen it just a couple times.
Yeah.
The risks, if I'm putting your level super high, so like super physiologic, is enlarged clitoris.
Okay.
Deepening of your voice and like facial hair growth, i.e. I'm turning you into a man. That doesn't happen until your levels are super high. And so with a cream or a gel, we're likely not going to reach that level. Can it happen? Sure. So I tell everybody, just in case, I'd rather you know what to look for, but I haven't seen it personally with the gels and the creams. It's more likely to happen with a pellet than it will with anything.
Okay.
The pellets, there's a lot of women that love pellets, and the pellets, it's all about the dosing, in my opinion.
Okay.
Yeah.
All right. So you're saying that as long as women are started on a physiological dose for a woman, right?
Yes.
That they're not going to turn into a man.
They shouldn't. Yeah, I hope not. I haven't seen it yet.
Yeah. Well, and I think the only side effect I had were the headaches but I knew enough to know, right? Like I need to go back. I need to speak to an expert in the field. And then my dose was dropped down again and then titrated up really slowly after that.
Yeah.
Slowly over like 6 months slow.
And the
titration.
other thing too is like when you look at the testosterone levels on a lab result, normal from one lab to the next changes, and it also changes based off a region, right?
Oh,
So
okay.
reference ranges for a lab in California is going to be different than Virginia. They're going to be different because they base them off the
Interesting.
local population.
Okay.
So yeah, I mean, it's not going to be a huge change, but it is going to be different. So let's just say here for one of our labs, I think they give a reference of like 5 to 55 for testosterone.
Okay.
So if we pull your testosterone level and it says you're 20, you're going to
Mm-hmm.
go, okay, well, I'm normal. But
Mm-hmm.
what if you 10 years ago was 45?
Yeah.
You dropping from
Right.
45 to 20, you're going
Right.
to feel that. But
Yeah.
both are still physiologic normal levels, right? So that's where you kind of get more into the functional, not feeling like myself, I'm not me again, and getting you right. So we're not putting crazy high numbers. We're getting you back to a normal you is the goal.
Well, and that makes sense. And I think so. The way I understand it, right, is that testosterone starts a slow, steady decline
Mm-hmm.
for
Yeah,
women, right? It's not erratic like the estrogen is in
correct.
perimenopause.
Correct.
So it's kind of like women don't really see it because it sneaks up on them.
Yes. Yep.
Okay.
Yep,
Yeah.
it sneaks up. And then sometimes because your estrogen is low, we'll get like these dark, coarse, curly hairs because then your testosterone is almost dominant at that point.
I see. Even though they're both low, it can
Yeah.
seem like
Because,
testosterone.
yeah,
Oh,
because we
wow.
tend to
That's
have
important.
more testosterone than
Yeah.
estrogen in general,
Yeah.
right?
Yeah.
In perimenopause, because you alluded to it. So I always tell women to kind of talk about that volatility that happens with our hormones. Our body has done the same cycle with hormones every month of every year of our lives from puberty until now, right?
Yeah.
And so your body is going to try and do what it has always done. And that's where the chaos comes in perimenopause because your estrogen is coming up to try and ovulate and it can't do what it needs to do. And so then it's going to go, oh, let's go again, guys. And it's like, oh, I
Yeah.
can't do it. Let's go again.
Yeah.
So in peri, we are on this roller coaster
Yeah.
that we did not ask to be on. So one day we're up here and we're loving life. We're like, hey, everything's
Yeah.
great. The
Yeah.
next day,
Yeah.
we're wanting to choke everybody because
Yeah.
they're on our nerves, right? And so we don't understand it. Nobody around us understands it.
Sure.
Right. And so that's what that is. And so in perimenopause, because estrogen ranges on a lab is anywhere from like 20 to like 400-ish. In
Okay.
peri, you can be 300. Cool. You're still perimenopause because I caught you up here.
Yeah.
Or you can be 10. Cool. Still peri because I caught you here. Right. So,
Yeah. And I
so
don't
that's
think
why,
women realize that volatility. Because
yes.
they're like, oh well, I got my labs checked and I'm fine. And I'm
Because
like,
you fell somewhere between 20 and 400, right?
yeah. Yeah.
So you're normal because you're in that reference range. So it's the whole picture and kind of your symptoms, everything put together. Your follicle stimulating hormone, which is, I always tell people that's the brain, that's the boss monitoring the
Yep.
employee, the ovaries. And when those ovaries aren't giving enough estrogen, that FSH is going to go up because the boss is going to say, give me more, right? And so you won't always see that FSH go up in peri, so you use symptoms. But in general, we're talking a lot about labs, so I don't want to discount the people that don't draw labs because there are menopause practitioners that don't even look at labs. And I kind of understand why, and I'm okay with that. You can treat perimenopause and menopause technically without labs because
Right.
as long as they haven't had a cycle for a year, they're postmenopause. You know that based off of their history. And so you're then treating the human in front of you, not their lab results. But I always want to know kidney and liver function. So that's why I test it. And
Okay.
then I know the woman in front of me wants to know her labs.
Sure.
So I get it just as a baseline. But I always say that because I'm like, sometimes women are like, well, they didn't even check it. And it's like, well, because they may feel comfortable treating you without them. And that's what I do is I treat to their symptoms. When they feel
Sure.
better, that's their recipe.
Well,
So
and that's right because every woman can be different, right? Different women require different doses
exactly.
of estrogen, progesterone, and testosterone, right?
Yes.
Yeah.
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 So I think a lot of practitioners, what we do is we use like a symptom questionnaire, like a menopause rating scale.
Yeah.
And I ask those questions every single visit, and the answers to those questions tell me what a woman's body is asking for. Your symptoms are telling me what you need. And so then we keep adjusting doses until your symptoms go away or they're pretty much gone, right? It's not 100% gone, but usually what I tell patients is I say, when you feel back to you, when you're you again, that's your recipe.
Well, and I give those checkers out too in my office, right? I do a perimenopause one, perimenopause, menopause, and then I do one for GSM. And then I have them take it into their provider. Here are my symptoms.
Awesome.
So, right, because so many, I've never had a woman walk into my office and have had a checklist before.
Yeah.
A screener.
Yeah.
Not one. And so I'm like, you need to take this in. So, because they're two different ones, right? You've got the mood one, the physical mood and the mood, and then you have GSM.
Mm-hmm.
Can you say a bit about GSM?
Oh, I love talking about GSM.
Okay, yeah. GSM, what it is. People are like, what does GSM stand for? Yeah.
Okay, genitourinary syndrome and menopause. I just say it's all the pelvic stuff, right?
Yes. Yeah.
So vaginal dryness, pain with intercourse, increased urinary tract infections, very classic. But I think as things start to change down there, first of all, we may not realize it right away if we're not sexually active. So estrogen regulates collagen. Collagen is what thickens the skin. So think of like as we age and we become elderly, like our arms get that thin, crepey skin. You can see through it.
Yeah.
Skin is skin. Same thing happens down there, not to that degree, obviously, in perimenopause and menopause, but it thins out. So you put any pressure on it, i.e. intercourse, it's going to tear. So a lot of women will get, it feels like razor blades. It feels like glass down there.
Yeah.
It just hurts, right? And it can hurt on the outside. It can hurt on the inside. And so you also have, because estrogen regulates collagen, which regulates the microbiome. So the healthy bacteria that's in there, you're now more susceptible to infections. So bacterial vaginosis, yeast infections. And if this is the vaginal opening, I'm trying to do this backwards on camera, and this is the urethra.
Yes, you got it.
That tissue between here thins, right?
Yes.
Because collagen's no longer there. So the urethra moves closer, which means things can now get cross-contamination. So we get more urinary tract infections. Urinary tract infections, if women get them all of a sudden midlife, it's almost always going to be peri or menopause, right? So if you have gone through years, no UTIs, and all of a sudden UTIs are hitting, that can be an issue. And so estrogen is going to help that. Later in life, UTIs can actually be extremely harmful. They can cause sepsis. So that's a big deal that can land you in the hospital and be truthfully harmful.
Well, and I think this is something that Dr. Rachel Rubin talks about all the time. Like this is her banner is the GSM and the UTIs. And she talks about her own mom. It's just like, this is what kills little old ladies are these UTIs.
Yes.
Right?
Yes.
Yeah. And it's completely preventable.
And vaginal estrogen is safe pretty much for anybody that is like lotion. If I put lotion on my arm, it only goes here. Vaginal estrogen only goes there. So any woman that has fear of estrogen or has some kind of history that prevents systemic, like head to toe estrogen, she can always do vaginal. Like there's very few reasons why we would ever say no.
Right. Because it doesn't travel systemically, right?
No. Yeah, it doesn't. So in my opinion, it's only a benefit. Yeah.
Well, and I think for women, there's just the cultural messaging, right? Is that sometimes sex is uncomfortable, that sometimes we're supposed to have sex even if we don't want to have sex. If you're in this is more in a traditional heterosexual relationship. Right. That women are supposed to be having sex, even if they don't want to have sex because they have to keep their male partner happy. And I just want to say that's a recipe for disaster. Yes. Because if you start having these little tiny micro tears, right, in the labia, or vaginally, or even with, if the clitoris starts to shrink up or starts to become irritated, that even if it's just a low level of uncomfortability, our bodies naturally will start to pull away. Yep. Right. Yep. And tighten up. Right. Yep. And we've got all these pelvic floor muscles. So our body naturally, emotionally is going to pull away. Our body follows. The pelvic muscles tighten up. And then sex is going to become even more and more uncomfortable, which women can sometimes unconsciously start resisting. Oh, I don't want to have sex. Oh, I I don't feel well, not tonight, all the things. And then it can become weeks and it can become months. And then it can just feel awkward to try to restart that again with a partner who's probably raring to go, right? Because you can get Viagra on every street corner these days.
Yes. Yeah.
Right? And that's not going to feel good for the woman.
Yes,
Right.
exactly.
Yes.
And you're correct, because then she, just like you were saying, she's going to tense up. And then you're going to have this subconscious reaction to where now the pelvic floor is tight. It is going to hurt because you're having muscle spasms. And so, yeah. So no, it's a thing. And so vaginal estrogen is going to thicken those tissues back up. Like, it is so incredibly easy, and the majority of women feel better with it, right? There are different ways to get estrogen into the vaginal tissue. So like the cream can sometimes be messy.
Yeah.
So not everybody loves the cream.
Okay.
But there's like a vaginal ring, there's a vaginal pill that you can insert, there's suppositories. You can get estrogen into a vagina many different ways. And you would be surprised. Like, it's actually fairly easy and it works for the majority of women.
And once again, this is why it's important to go to someone who's really well trained, like Cherie, because look, you have all these different options for vaginal estrogen, right? It's not one size fits all.
Right.
You've got to find something that you're going to do, because you're on vaginal estrogen for the rest of your life, right?
You can be, yes.
Okay.
Now, if you do systemic estrogen, so you go head to toe, there is a percentage of women that it will replenish from the inside out. Okay. So about 60% of those women will feel better with systemic estrogen, but 40% will always still need vaginal creams or vaginal estrogen.
So for those 40%, it's going to be important that they have something that they're doing consistently, right? Yeah. So it's got to be workable in their life.
Yes. But usually, like, it's a game changer for real. Women usually love vaginal estrogen.
So I had a girlfriend of mine. This is so funny. I had a girlfriend of mine and she was having symptoms. I'm like, you got to go. Yeah. I think I might have referred her to you. I'm like, you got to go.
Yes.
And she came back and she was like, this vaginal estrogen, I just want to stand on the street corner at every CVS and Walgreens and hand it out in a basket. I just want to go skipping down the street with it. It is such a game changer.
Yes. Yeah. It's one of those things where it's like, why have we been suffering? Like, sex should not hurt. We should be living our best lives. We should, right? Like, yeah, this shouldn't even be a thing. And it's such an easy answer. So I'll stand on the street corner with her.
Handing it out. Here you go. Okay. So there's so much more to talk about, Cherie.
Yeah.
I feel like we could probably go for another hour.
I think so too.
So maybe you'll come back on the podcast.
Yeah.
Because I still have more questions,
I think
tell me, where can people find you? So you serve the Las Vegas, Henderson area, or are you in all of Nevada? Like, where can people come find you?
Wonderful question. Thank you. So I am in Las Vegas. I'm physically in Henderson, but that's Las Vegas for non-locals. So I serve all of Nevada. So I can do telehealth for women that are not physically there. I just want women to get cared for. So I will do that. And then I also do telehealth in Utah and Arizona. So Nevada, Utah, Arizona.
States. Yeah.
You are my jam. That's my women that I take care of. And so I love it. I love everything we do. In clinic, we see patients and we take care of them. And we actually are a menopause clinic. So the name of the clinic is Xena Health.
Okay.
Xena's with an X, Xena Health.
Okay.
LV.com. It's a menopause clinic. So I love that because, I'm family nurse practitioner, women's health nurse practitioner. I'm like, I don't want a primary care clinic. I don't want a gynecology clinic. I want a menopause clinic. And that's kind of what we created. Now we do offer men's therapy because as the women feel amazing, the next question is, well, can you take care of my husband?
Sure.
And so we do. And I always halfway giggle. I've debated because the front sign on my door says women's health and menopause, and men just open that door and come right in. And I'm like, do I need to take that off? They don't care. They're like, she told me to come here. I'm here.
Well, I'm sure they see their partners and wives feeling so much better, right?
Yeah.
That they are just like, I want to feel better just like she is. Who
Yes.
cares what it says?
Yes. And then, a lot of times men come with their wives. And I love it when that happens because then they're like, I didn't even realize this is a thing. And so that would be the thing I would recommend too, is once women find a practitioner, which we didn't talk about that, but If you're not Arizona, Nevada, Utah with me, go to menopause.org. That's how you find someone in your area. Okay. And then when you find that person, try and take your spouse with you, take your significant other, because it may help some of those dynamics to realize like it's not just us going crazy and being weird. It's actually a thing.
It is a thing.
And sometimes that's healing. It's healing for both the woman and the other person, the partner, to go, oh my gosh, I didn't realize that they've been suffering, and it may change some dynamics.
Well, and absolutely. And it's like sometimes in midlife, a marriage, a relationship can be completely transformed.
Yes. Yes.
And, the medical piece, the hormone, it's like without it, then what? You're going to try to balance on a 3-legged chair. You're just going to fall over.
Right.
Right?
Right.
So important. But this is a time of life where couples can just really have a restart to their relationship.
Yes.
They can learn new ways to connect with each other. A lot of times kids are teenagers or they're leaving the house. And so who they were when they first met may not be who they are now. I think is a really transformational time for women and for their relationships.
You're giving me goosebumps, Rachel. No, because that's what I say. I'm like, my goal is to help women live their best life, whatever that means to them. Like, we don't have to take anything less than amazing. There's stuff that will help. And you're right. This is the second half. Like, this is now when it's our time, right? So why suffer? Why deal with it? Like, live your best life. Go have an amazing time. We just have to realize that there are answers and there are options, and we don't have to take anything less than amazing.
Yeah. Okay. So they can find you. They can find you at menopause.org.
Yes.
They can find you at your website.
XenaHealthLV.com.
Okay. And you're on Instagram as well, right?
Yes. XenaHealthLV.
Okay. Is there anywhere else they can find you?
Facebook. It's the same one. XenaHealthLV. LV is for Las Vegas. So, yeah. Yeah. Thank you.
Yeah. And just to recap, if people are looking for a trained physician and they can't get to you, Cherie, they can go to menopause.org. And to also, when you go to see your clinician, right, you've talked about some really important things today that you want that clinician to be able to have several different options.
Mm-hmm.
It shouldn't be, I only prescribe one thing to everybody, right? It should be several different options of estrogen, progesterone, testosterone, and vaginal estrogen, right?
Yes.
So whoever they see should be able to talk like you're talking today, right? They should have knowledge extensively on all the different formulations.
I hope so. But I do think there's more and more people that are tackling this. So not everybody may be an expert. I'm not an expert. Not everybody may be an expert. But as long as they're trying and they're knowledgeable and they're with menopause.org, I would trust them.
Great. Yes. Okay. Thanks so much for being on the call.
Yes.
Yeah.
Well, it's good seeing you. Thank you for having me.
So great to see you. Yeah. And, if you're up for it, we'll do another one because there's just so much more to talk about. We'll probably get a lot of questions. Yeah.
Yeah. We didn't even get into like the different routes of hormones and all of that kind of stuff and the risks.
Right.
I know. We need to do more.
I still have a whole list of questions here on sexual and relationship health, mental health and brain changes, lifestyle and integrative care. So we'll cover that next time.
Okay. Looking forward to it.
Okay. All right.
Thank you. Okay. Bye.
Bye.
Thanks for spending time with me today. I hope you found something helpful, validating, or just a little more human in our conversation. Remember, while I'm a licensed therapist, I'm not your therapist, and I'm not a medical doctor. This podcast is for informational and educational purposes only and does not constitute medical or mental health advice. For personalized care, please consult with a licensed healthcare provider or mental health professional trained in the area you're seeking support. You deserve expert guidance that's tailored just for you.